picture this scenario. It's a chaotic Tuesday afternoon in the emergency department. The background noise is that steady hum of beepers, footsteps, and, distant shouting that you only get in a hospital.
I know it well.
The automatic doors swing open, and paramedics wheel in a 65-year-old man. And the energy in the room, it just shifts immediately.
Yeah.
He's clutching his chest, his face is ashen, pale, and he is visibly terrified. Sweat is just beading on his forehead. He describes the pain as crushing. He literally uses the words like an elephant sitting on me.
Which is the classic description. It's so visceral.
Exactly.
Yeah.
But it's not just sitting in the center of his chest. It's moving. It's radiating. It is shooting down his left arm and crawling up into his neck, clamping onto his jaw.
And that radiation is key. I mean, it's the kind of thing you see in movies, but when it's happening right in front of you, the physiology is just screaming for attention. The body is effectively shouting out coordinates.
Right. But here's the detail that matters most for our discussion today. The doctors start questioning him, trying to build a history. And he tells them, I've had this pain before.
Okay.
He says usually he gets it when he's climbing stairs or digging in the garden. And usually if he just sits down and rests for 5 minutes, it goes away.
Which is a textbook description of angina pectoris. It's a supply and demand issue. The heart works harder, it needs more blood, can't get it through a narrowed artery, and so it cries out in pain.
And rest lowers the demand.
Rest lowers the demand and the pain stops. Simple as that.
Right. But, and here is the terrifying but, this time he wasn't digging in the garden. He was just sitting in his recliner watching the news.
Yeah.
And this time, the pain isn't going away. It's relentless.
And that is the pivot point. That shift from pain on exertion to spontaneous unremitting pain, that tells the clinician we have moved from angina insufficient flow to a myocardial infarction. The blood flow hasn't just slowed down, it has stopped.
So the heart muscle isn't just hungry for oxygen.
It's dying.
And that is our hook. That is where we start today. Because to save this man, to understand why the pain travels to his left arm of all places,
Yeah.
I mean, why not the right? Or why rest helped before but won't help now? You need a map. You need the anatomy.
Precisely. Anatomy is often taught to students as just a list of Latin words to memorize, which is tragic. It's not a list. It is the schematic diagram of the machine. If you don't know the arrangement of the coronary arteries, you cannot diagnose which part of this man's heart is dying.
You can't explain the jaw pain.
If you don't understand the nervous system connections, you can't explain why his jaw hurts when his heart is the problem. It all gets back to the map.
So that is our mission today. We are taking a deep dive into the introduction chapter of Snell's Clinical Anatomy.
A foundational text. I mean, maybe the foundational text for many of us.
An absolute foundation. And we should be clear right up front. We are not reading the book to you. We are interpreting it. We're pulling out the introduction specifically because it sets the rules for the entire language of medicine. If you don't understand the syntax, you can't read the code.
And frankly, reading textbooks is becoming a bit of a lost art. Students so often skip the introduction to get to the cool stuff like the brain or the heart.
Right.
But we want this deep dive to be a ready reckoner, a primer. We want to give you the anchors and the mental models so that when you do go and open the book, and let's be clear, you absolutely should open the book, it feels familiar.
Like you've been there before.
Exactly.
So think of this as the trailer that convinces you to read the novel. So if you are a student, a curious learner, or just someone who wants to know how the machine works, stick with us. We are going to build the human body from the ground up, starting with the rules of the road.
The true north of medicine, if you will.
Let's start exactly there. Orientation. I mean, if I say left and you're facing me, my left is your right, in a casual conversation, that's just annoying.
Right.
In a surgical theater, that is a disaster. So how do we solve that?
We solve it with the anatomical position. It is the universal reference point for all medical description. It doesn't matter if the patient is lying face down, curled up in a ball in agony, or hanging upside down.
Right.
When we describe their anatomy in the chart, we imagine them in this one specific rigid pose.
Okay, paint the picture for me. What does this default human look like?
Okay, so you're standing erect, eyes looking forward, level with the horizon, arms hanging by your sides.
Okay.
Lower limbs together, toes pointing forward. But, and this is the detail that trips up every first-year student and can mess up your understanding of the entire upper limb, the palms of your hands must be facing forward, anteriorly.
Okay, I want everyone listening to do this right now. Unless you're driving, of course. Stand up. Put your arms by your sides. Now, instinctively, if you just relax, what do your hands do? They rotate inward. Your thumbs point toward your thighs. The palms face your body.
Correct. That is the relaxed posture. But the anatomical position demands you rotate your hands so the palms face the room and your thumbs point away from your body.
Why? I mean, is this just anatomist being difficult?
No, it's purely mechanical.
Hmm.
Feel your forearm. You've got two bones there, the radius and the ulna.
Mm-hmm.
When your palms face your thighs, that relaxed position, the radius actually rotates and crosses over the ulna. They form an X.
Oh, really? I never realized that.
Yes. If we described anatomy in that relaxed position, describing the muscles, arteries, and nerves would be a nightmare because the bones are twisted over each other. By turning the palms forward, we uncross those bones.
So they run parallel.
They run parallel from elbow to wrist. It simplifies the map.
So the unnatural position is actually the clearest map. It's like untangling the wires before you write the manual.
I love that. Okay, so we are standing in the anatomical position, palms forward. Now we need to slice the body up to look inside. We have these invisible panes of glass or planes that anatomists love to talk about.
Right. These are crucial. If you ever look at a CT scan or an MRI, you are looking at the body in slices. You need to know which way the slice was made.
So the first one is the median plane. Imagine a giant sheet of glass slicing you perfectly down the center, dividing you into equal right and left halves.
Simple enough. But what if the slice is parallel to the middle but off to the side? Like slicing off just my shoulder.
That is a sagittal plane. It's parallel to the median, but the slices are unequal. A lot of imaging is done in sagittal sections to look at the spine from the side, for example.
Okay. Now, what about the one that cuts the front of me from the back of me?
That is the coronal plane, also called the frontal plane.
I have a memory anchor for this one that I think works really well. I think of a corona or a tiara.
A tiara, okay.
Yeah. If you wear a tiara on your head, it sits across the top from ear to ear. If you were to take a giant sheet of glass and slide it down through that tiara, it would slice your face off in the back of your head. It divides front and back.
That is a very vivid, slightly gruesome, but very accurate image, yes. Coronal divides anterior front from posterior back.
And the last big one is the transverse plane.
The horizontal slice. It cuts the body into upper and lower parts, like a magician sawing a person in half.
Right.
But there is a nuance here that Snell points out, which is fascinating, and it catches people out. Transverse literally means perpendicular to the long axis.
Wait, isn't that always horizontal? I mean, if I'm standing up, my long axis is vertical, so the cut is horizontal.
In the trunk, yes. But think about the foot. What is the long axis of the foot?
It runs from the heel to the toes, so horizontally along the ground.
Exactly. So a transverse cut of the foot is actually vertical. It's like slicing a loaf of bread. If you ask for a transverse scan of the foot and expect horizontal layers like a cake, you're going to be looking at the wrong thing.
Oh, that is tricky. So context is king. You have to know the long axis of the structure you were talking about.
Always.
Okay, let's rapid fire some of these location terms because they come up constantly in clinical notes. We mentioned anterior and posterior, front and back. But Snell mentions some special cases for the hands and feet.
Right, because the arms and legs can twist front and back, get confusing. So for the hand, the front or grasping surface is palmar. The back of the hand is dorsal.
Like a shark's dorsal fin.
Exactly, it's on the back.
And the foot.
The top of the foot, the part you look down at when you tie your laces, is the dorsal surface. The sole of the foot is the plantar surface.
Hence, plantar warts are on the bottom of the foot.
Exactly.
Got it. What about proximal versus distal? I always visualize a river for this.
That's a good analogy. Proximal is closer to the source, the root. Distal is the distance away, down toward the delta.
So, for the arm.
So your shoulder is the root of the arm. The elbow is proximal to the wrist. The wrist is distal to the elbow.
It's all relative to the attachment point.
Precisely. And then you have ipsilateral and contralateral.
Fancy words for same side and opposite side.
Correct. But clinically vital. Imagine a patient comes in, they've had a stroke, the damage is in the right side of their brain.
Okay.
But because the major nerve tracks cross over in the neck, their left arm is paralyzed.
So the paralysis is contralateral to the brain injury.
Exactly. Conversely, if you burn your right hand and hurt your right foot on the same side, those injuries are ipsilateral.
Okay, listener, quick check-in. This is the interactive part. Stand up again or just visualize it. Put yourself in the anatomical position. Palms forward. Now, point to a structure that is proximal to your hand, but distal to your shoulder.
Think about that river. Closer to the source than the hand, but further away from the source than the shoulder.
Hopefully you are pointing at your elbow or your forearm.
If you pointed at your neck, rewind. You went upstream instead of downstream.
Let's get things moving. The source material has a great section on the vocabulary of movement. This is where things get actionable. I mean, if you write, the patient moved their arm in a chart, you might as well write nothing. We need specifics.
We need the hinges. Flexion and extension.
Start with the basics.
So flexion closes the angle of a joint. It folds the limb. Extension opens or straightens it. Think of the elbow. Bring your hand to your shoulder. That's flexion. Straighten it out. That's extension.
But there is a trap here, a massive trap. The knee.
The knee is the rebel. In the arm, flexion moves the limb forward, anteriorly, but because of how our legs rotate during embryological development, they actually twist inward 180 degrees. The knee works backward compared to the elbow.
Wait, so knee flexion.
Bends the leg posteriorly, bringing your heel to your buttock.
So if a report says the patient's knee was flexed, the leg is bent back. But if the elbow is flexed, the arm is bent forward. That is confusing.
It is, until you use Snell's hint. Think of the fetal position.
Okay, curling up into a ball.
Exactly. When you curl into a ball, everything you do is flexion. You flex your elbows, you flex your spine, and what do you do with your knees?
You pull into your chest.
Right, your heels go to your bum. That is flexion.
I love that. Curling into a ball is universal flexion. That solves the knee confusion immediately. Now, the foot has its own fancy terms again, doesn't it?
It does. To avoid confusion, we don't just say flex the foot. We say dorsiflexion if you lift the toes up toward the shin flexing, toward the dorsal surface. And if you point the toes down, like a ballerina standing on tiptoe.
That's plantar flexion. I remember planting the toes down into the earth.
Perfect anchor.
Okay, what about moving things away from the body?
Abduction and...
Adduction. I have the ultimate anchor for this. Alien abduction.
Go on?
If an alien beam comes down and abducts you, it takes you away from the earth. So abduction is moving a limb away from the midline, lifting your arm out to the side.
That works perfectly. And adduction is adding the limb back to the body, bringing it down to your side.
Then we have rotation.
Spinning around a long axis. Medial rotation turns the front of the limb inward. Lateral rotation turns it outward.
And then the cone of movement, circumduction.
Ah, this is a combo move. It combines flexion, extension, abduction, and adduction. Think of a cricket bowler winding up, or a baseball pitcher. The hand traces a circle, but the limb traces a cone shape in the air.
Now, we have to talk about the forearm special. The soup.
Ah, pronation and supination. This happens only in the forearm. It's that movement we talked about earlier, the radius rotating around the ulna.
And the metaphor is, supination's holding a bowl of soup, your palm is up.
And pronation is pouring it out, turning the palm down.
Simple. But Snell puts a warning label here. Do not confuse this with the foot.
Right. If you run or buy sneakers, you hear about pronating feet. Clinically, that usually refers to the arch collapsing. But strictly anatomically, pronation and supination are forearm definitions.
So in the foot.
In the foot, the terms are eversion, which is turning the sole out, and inversion, which is turning the sole in.
So if you roll your ankle playing basketball, the classic injury where the sole turns inward, that's an inversion sprain.
Exactly.
Before we leave terminology, the expert in you probably loved the little rant in the source text about eponyms.
I did, I have to admit. The text is very stern about this. It essentially says we should stop using names like fallopian tubes or the circle of Willis or Eustachian tubes.
Why? I mean, those sound so distinguished. The circle of Willis sounds like a secret society.
It does, but it tells you nothing about the structure. If you are a student, fallopian tube is just a random name to memorize.
Yeah.
But if I say uterine tube, the name tells you exactly what it is and where it is. Snell argues for descriptive terms to lower the cognitive load.
But the text also admits
That clinicians never stop using the old names. We are creatures of habit. So unfortunately, the listener has to learn both. You need to know the uterine tube is the fallopian tube, otherwise you'll be lost on rounds.
Moving on to the hardware, let's talk about the casing of the machine, the skin.
It is so much more than a wrapper. It's the body's first line of defense, its radiator, and its sensor array. Anatomically, you have two main layers. The epidermis on top,
Right.
which is stratified epithelium, cells that get flatter and harder as they reach the surface. And the dermis underneath, that's the tough, vascular, connective tissue bit.
And there's a really cool clinical nugget here about shock. The text mentions that a patient in shock gets gooseflesh.
It's a survival reflex. Imagine that patient from our intro, the guy with the heart attack. His heart is failing, his blood pressure is dropping. His sympathetic nervous system, the fight or flight system, goes into overdrive to save him.
So it clamps down the blood vessels.
Yes, specifically in the skin. It shunts blood to the brain and the heart. That's why he goes pale and cold. But that same sympathetic signal hits the tiny muscles attached to every hair follicle, the erector pili muscles.
So the hair stands up.
Exactly. It creates goosebumps. So if you walk up to a patient and they are pale, clammy, and have goosebumps, they aren't just chilly. That is a red flag. Their sympathetic system is screaming.
That is fascinating. The skin also has appendages, hair, nails, sweat glands. But their depth matters, especially when we talk about burns.
It's a critical distinction. We talk about partial thickness and full thickness burns.
And how does the anatomy dictate the healing?
Well, in a partial thickness burn, you might destroy the epidermis and part of the dermis. But the hair follicles and sweat glands, they extend deep down. Their roots are safe. Those deep parts act like seeds. The skin can regenerate from those islands of epithelium and spread out to cover the wound.
But a full thickness burn.
You've burned the soil and the seeds. You've gone through the dermis. There's nothing left to regenerate from. That is why full thickness burns require skin grafts. The body can only heal from the edges inward, which is just too slow and causes horrible scarring.
Beneath the skin, we hit the fascia. I always think of this as the white, stringy stuff you see when you're preparing chicken.
That's it. You have superficial fascia, which is mostly fat, subcutaneous tissue. It's the insulation. But the deep fascia is the game changer. It's a dense, membranous layer, like a wetsuit that wraps the muscles.
And the text highlights a scary reality about deep fascia and infection.
Yes. Deep fascia isn't just a wrapper. It forms walls. It creates these compartments. So if you get an infection in your neck, for example, the pus doesn't just spread randomly. It follows the path of least resistance. It flows along the fascial planes.
So a tooth infection could travel down a fascial slide directly into the chest.
Exactly. It creates a highway from the mouth to the mediastinum, the space around the heart. This is a condition called Ludwig's angina. Knowing these planes tells a surgeon exactly where the infection is going to migrate.
That is terrifying. It's like the infection has a roadmap.
It does. And the anatomy is the roadmap.
Deep fascia also does something cool to wrist and ankle. It thickens up into bands called retinacula.
Think of them as wristbands. If you didn't have them when you flexed your wrist to lift a weight, your tendons would pop out of your arm like bowstrings.
Oh, wow.
You'd lose all your leverage. The retinaculum holds them down against the bone so they act like pulleys, nice and efficient.
Okay, let's go deeper. To the framework, the bones.
Right, first thing to unlearn. Bones are not dry, dead sticks. In the museum they are dry, but in your body, they are living vascular organs. They bleed when you break them.
And they hurt.
Oh, they hurt. The outer skin of the bone, the periosteum, is incredibly sensitive. That's why banging your shin against a coffee table is such a spiritual experience of pain.
I've been there. Why the shin specifically? Is it just me?
No, it's because the tibia is subcutaneous. There's no muscle to cushion it. It's just skin, periosteum, bone. You are striking that nerve-rich layer directly.
The text breaks bones down by shape. Long bones, short bones, flat bones. But let's focus on sesamoid bones. This is a weird category.
These are bones that grow inside tendons. The classic example is the patella, the kneecap. It's buried inside the quadriceps tendon.
What is the point of floating a bone in a tendon?
It's all about leverage. If the tendon laid flat against the knee joint, the angle of pull would be really shallow. By putting a marble or a kneecap under the rope, you push the rope away from the pivot point. You increase the angle. It makes the muscle significantly more efficient.
Engineering at its finest. Now, bone development. This is where we get into the soft baby head discussion.
Right. Membranous ossification. The skull bones form directly from membranes, leaving gaps, the fontanelles.
The soft spots.
The soft spots. This allows the skull plates to slide over each other, to mold, so the baby can actually fit through the birth canal.
If the skull were one solid fused bone at birth,
we wouldn't be here as a species. Simple as that.
Conversely, long bones grow from cartilage models. Endochondral ossification.
And this leads to a classic pathology mentioned in the text, rickets.
This is the vitamin D deficiency, right?
Yes. To turn cartilage into hard bone, you need calcium. But to absorb calcium, you need vitamin D. In rickets, the child is deficient. So the cartilage grows, the bone gets longer, but it doesn't mineralize. It stays soft.
So when the child stands up,
the weight of the body actually bends the soft leg bones. That's why you get bow legs. It's a structural failure due to a chemical missing link.
Now, connecting these bones, we have the joints.
Three main types. You've got fibrous, like the skull sutures, effectively immovable. Then cartilaginous, like the discs in your spine. They have a little give, usually for shock absorption.
And they're the big ones. Synovial joints.
The movers. Shoulders, knees, elbows. They have a cavity, they have fluid, synovial fluid, and they have a capsule.
There's a concept here that Snell drops called Hilton's Law. This feels deep.
It is. It connects everything. Hilton's law states that the nerve supplying a joint also supplies the muscles moving the joint and the skin over the insertions of those muscles.
Okay, unpack that. Why does that matter?
It's a protection circuit. If you sprain your knee, the nerve inside the knee screams pain. That same nerve talks to the thigh muscles and says, shut it down, spasm, guard the joint.
Wow.
And it talks to the brain to make the skin feel sensitive or have referred pain.
So stiffness isn't just a symptom, it's a strategy.
Exactly. It is the body applying its own cast to stop you from doing further damage.
Now, what keeps these synovial joints from popping out of place? The stability triad.
Right. Factor one, the shape of the bones. The hip is a deep ball and socket, very stable. The shoulder, it's like a golf ball on a tee, very unstable.
Factor two, ligaments.
Ligaments hold bones together, but Snell gives a massive warning here. Ligaments are fibrous. They are not elastic bands. If you stretch them too far, they stay stretched.
They don't snap back.
Generally, no. Once you sprain an ankle and stretch those ligaments, that ankle is mechanically looser forever.
Which leaves us with factor three, the MVP.
Muscle tone. This is what saves us. The muscles surrounding the joint are constantly, quietly firing, effectively holding it together. The text uses the foot arches as the prime example.
The arches aren't held up by bone.
Not primarily. They are suspended by the tone of the muscles. Think of a suspension bridge. The bone is the deck, but the cables are the muscles.
Okay.
If you get exhausted or stand for days on end, the muscles fatigue and they let go.
Oh.
Then the weight falls onto the ligaments stretch and hurt, and eventually the arch collapses, you get flat feet.
So fallen arches is really exhausted muscles.
That led to ligament failure.
Which brings us perfectly to the engines of the body.
Oh,
muscles.
Skeletal muscles. We have origins, which is usually the fixed end, and insertions, the moving end.
But the architecture of the fibers is what caught my eye.
Yeah.
Parallel versus pinnate.
This is a classic trade-off between range and power. You can't have both.
Explain.
In a parallel muscle, like the sartorius in the thigh, the fibers run long and straight. They can shorten a lot. This gives you a huge range of motion, but there are fewer fibers packed in.
Okay. And pinnate.
Pinnate means feather-like. The tendon runs up the middle and short fibers come in at an angle like a bird's feather. Because they are angled, you can pack thousands more fibers into the same space.
More fibers equals.
More power, a lot more power. But because they are short and angled, they can't shorten very far. So pinnate muscles are for power, like the quadriceps. Parallel muscles are for speed and reach.
Now, muscles don't work alone. It's a team sport.
Always. You have the agonist, the prime mover, the one doing the job, say the quadriceps kicking a ball.
But if the quadriceps shortens, the muscle on the back of the leg, the hamstring has to stretch to let it happen.
Exactly. That is the antagonist. The nervous system has to tell the antagonist to relax while the agonist fires. If they both fire at once, you're rigid. You go nowhere.
And then you have synergists.
These are subtle but vital. Try to make a tight fist right now.
Okay, I'm clenching.
Look at your wrist. It extended slightly, didn't it? It cocked back.
It did, yeah.
Those are the wrist extensors acting as synergists. If they didn't fire, the tendons flexing your fingers would also curl your wrist forward, and your grip would be incredibly weak. The synergist locks the intermediate joint so the prime mover can work effectively on the fingers.
There is one last muscle concept that just blew my mind.
Yeah.
Paradoxical action.
Oh, this is fun. Imagine you are holding a heavy glass of water, and you are lowering it gently to the table.
Okay, my arm is straightening, so my triceps, the extender, is working.
No. Gravity is pulling the glass down. If your triceps fired, you'd smash the glass into the table.
Oh, right.
You are actually using your biceps, the flexor, but you are slowly lengthening it to control the descent. It's an eccentric contraction.
So a flexor is controlling extension.
Paradoxical, but necessary. You are paying out the rope against gravity.
Okay, let's check in on tone before we wrap up. Tone is the resting state, right?
Yes. Even when you sleep, your muscles have a low level of contraction. If you cut the nerve, the muscle goes flaccid, completely limp.
Right.
But if you have a stroke or a spinal cord injury that cuts off the brain's control, the local reflex loops can go haywire and the muscle becomes spastic tight and rigid.
So flaccid means the wire is cut. Spastic means the brain is disconnected, but the local power is surging.
That's a very good way to visualize it.
We've covered a massive amount of ground. From the palms facing forward to the fascial highways, the bowed legs of rickets, and the paradox of putting down a glass of water.
We have built the map.
If you were listening to this and you felt a bit lost on the coronal plane or the difference between agonist and synergist, don't worry.
Rewind. Or better yet, open Snell. Look at the diagrams. Anatomy is a visual science. We can give you the words, but the book gives you the territory.
And remember, the mission here. We are not learning this to pass a multiple choice quiz.
No. We are learning it for that 65-year-old man in the intro. When he comes in with chest pain, you aren't just seeing pain. You are visualizing the nerve pathways, the blocked artery, the sympathetic reaction causing his goose flesh. You are seeing the machine behind the symptoms.
I want to leave you with a thought based on that Hilton's law. We talked about how the nerve to the joint also controls the muscle and the skin.
The interconnectedness.
Right. Think about that the next time you feel stiffness in a joint or a vague ache. We usually ignore it or try to push through, but anatomically, that is your body's preemptive strike.
It is.
Could it be that stiffness is your brain shouting, stop moving, before you even feel the hurt? The anatomy suggests the body's protecting itself before you're even consciously aware of the danger.
It's a humbling thought. The machine is always listening.
Thanks for diving deep with us today. Go read the book.
See you next time.